Good evening, everyone. How are you all? All right. So tonight we are going to start a new topic, pediatrics. Are you guys excited? Because so far you have learned psychiatry, you have learned cardiology in details. Now we are going into another subject, which is pediatrics. Now, before we start, I just wanted to let all of you know that because now from 6th of April, so from tomorrow, the the daylight saving time will be decreased, like it will be stopped, and the time will go back to 1 hour. So till now we were taking class from 8:30 p.m. Now from 7th of April, the classes are going to be 1 hour backward, which means it will be 7:30 p.m. Sydney time. Okay, so we will make the announcement tonight on your Facebook group, but I just wanted to let you know because you guys should know it because you are joining the live sessions. I hope it will not make any changes in your country's area or in your day-to-day life, but it is important for us because like if daytime saving is getting stopped, then we also need to go back to the usual time. Okay. So starting with the pediatrics, so the research that you need for pediatrics is JAM 8th edition. So JAM has got a lot of chapters for pediatrics, and then we will also take a good amount of help from Kaplan Step to CK. The very good website for any kind of pediatric related questions is RCH. So throughout the session, we will show you a little bit from RCH also, but if you can read RCH guideline for the important topics. And definitely our lecture notes and then the Q bank. So I'll show you that the JM 8th edition chapters. So part 6, starting from chapter 83 till chapter 90. So all these chapters are pediatric chapters in your John Murtagh. Okay. So, and we will take a lot of help from these chapters as well. And no, it's not on the portal, Dr. Ayman. We have given a QBank link in your Facebook course group. So search the Facebook group in the featured section. So if you go to the featured section, you will see we have provided some link of the QBank. So go there, you should be able to find some, okay? All right, now let's start with pediatrics. There is a lot to discuss from pediatrics, and don't get overwhelmed because it is a lot. So we'll be discussing all the important topics that comes in your exam, but again, even the important topics is vast. So pediatric preparation can take a while. So it might even take 2 to 4 weeks for you even to understand pediatrics. So it is normal. So don't get frustrated about it. So first of all, we're starting with the respiratory distress in a newborn. So this is from Kaplan Step to CK. So what are the respiratory disease or what are the main causes of respiratory distress in a newborn? So it could be respiratory related, could be non-respiratory. Non-respiratory are mainly cardiac, could be related to hematology. Those are the ones. But respiratory ones are important. So we have got RDS, which is respiratory distress syndrome. We have got transient tachypnea of the newborn and meconium aspiration syndrome. So these are the three most common cause of respiratory distress in a newborn patient. Could be pneumonia, diaphragmatic hernia, choanal atresia as well. So what is respiratory distress syndrome? Respiratory distress syndrome means that when a child is born premature, they have got underdeveloped lungs, and because of underdeveloped lungs, they have lack of surfactant. And surfactant is the product which makes the lungs expand. So if there is lack of surfactant, the child's lung will not expand, and after that, child will have respiratory distress if they are born earlier than 34 weeks. So most of the time, by the time baby becomes 34 weeks old, there will be surfactant production, and that usually helps the lung expansion. But if there is a premature baby, which means before 34 weeks, then there will be a chance that child can develop respiratory distress. Baby will have respiratory distress within the first minute after birth, and gradually it will get worse over the next 48 hours. So the main cause is deficiency of mature surfactant, and the primary problem is hypoxemia, right? Because the child is not able to take good breath. If a child having increasing respiratory distress, then tachypnea, increased respiratory rate, getting cyanotic, hypoxic, and you know that it's a premature baby, then you think of RDS or hyaline membrane disease. What will you do? So your initial test will be chest X-ray. And in the chest X-ray, you can see ground glass appearance or air bronchogram. So ground glass appearance means it's kind of a haziness or cloudiness on the chest X-ray. So you can see it doesn't look clear, right? It looks like a glass on the top of the lung. So this is called ground glass appearance. Sometimes you can see this kind of air bronchogram, as you can see this line over here. So you can see this kind of air bronchogram, but mainly hazy or ground glass appearance is the main finding of RDS. If they ask what is the most appropriate or diagnostic test, that is LS ratio, which is lecithin to sphingomyelin ratio. How will you treat the patient? The initial treatment is oxygen because child will have hypoxia, and most effective treatment is intubation. So most of the time the child will require intubation in this case. Okay, how to avoid it? Basically, if we can avoid prematurity, we can avoid RDS. Or sometimes if you know that the child is going to be born within few days and the child is less than 34 weeks, then you can also give antenatal steroid to bring the lung maturity. So that's one of the way to bring the lung maturity in a premature baby. So that's RDS. Now, this is some of the guideline which you guys can follow. So one of the guideline is from queensland.gov.au and another is from Western Australia. So in here, they have discussed about various respiratory distress and everything. So if you have some time, go into this link and read a little bit. The another cause for respiratory distress in children is transient tachypnea of the newborn or TTN. So transient tachypnea of the newborn is common in any child, but it is common in children who is like with term. So term baby. What is term? Term means between 37 to 42 weeks. So if a child is term baby, and most of the time they are delivered by cesarean section, and they can have a bit of respiratory difficulty after birth, and that is what we will call as TTN. So the main pathophysiology is slow absorption of the fetal lung fluid, reducing the lung capacity, and that's why the child having breathing difficulty. Now, most of the time it will get better by its own within hours to few days. But if you want to know exactly what is going on, you do a chest X-ray, and in the chest X-ray you can see this finding like fluid end fissure, air trapping, perihilar streaking, which is very hard to see in a chest X-ray, which usually they will not give you in the exam. They sometimes ask you what is the X-ray finding of a child suffering from TTN. Then you need to know that what are the findings that you can find. Okay. So TTN is common in in a term baby, and cesarean section is also one of the risk factor, but it will get better. And if you do a chest X-ray, you will be able to diagnose the condition. So you have got for preterm baby, it is RDS. For term baby, it is transient tachypnea of newborn. And for post-term baby, that means if a child is born after 42 weeks, that's post-term baby. For post-term baby, meconium aspiration syndrome is one of the cause. So sometimes the child can aspirate meconium, and once it has become more than 42 weeks, the meconium starts to get more and more thicker. So that thick meconium can be aspirated, and when they aspirate it, it can cause airway obstruction, and it can also cause pneumonitis. Okay, so that's basically what happens. So especially after 42 weeks, the meconium starts to get more and more thicker, and it can cause a airway obstruction, causing breathing difficulty in a child. If you want to confirm meconium aspiration, you do a chest X-ray, and you can get this kind of finding like patchy infiltration, you can get flattening of diaphragm, etc. What we normally do in a child having meconium aspiration syndrome, that child will need intubation. If you see that child, like when the child is getting born, and when you are delivering the child, and if you see that there is lots of meconium around the mouth, then you can also suction that. So you can suction the meconium out, and then you can start oxygen and intubation. So basically the treatment is, if there is meconium that you can see, then you just suction it and then start the child with intubation. Okay, so intubation is the main treatment for meconium aspiration syndrome. Clear, guys? So these are very important. It comes in exam a lot. So just remember that if it is RDS, it is premature baby, usually will get it. Treatment will be intubation, but you can try oxygen first. Then TTN, usually nothing needed to be done. If oxygen is very low, you can give them oxygen, that's it. And then meconium aspiration syndrome, common in postnatal or post-term baby. And chest X-ray is your best test. And the treatment will be suction with intubation. Suction is only needed if you can see that there is thick meconium around the mouth or inside the oral cavity. Otherwise, routinely, we don't do suction in this child. That's one of the other mistake a lot of candidates do. Just because it is a post-term baby, they just commonly do suction for every child. It's not needed for every child to have a suction. Okay. Moving on to diaphragmatic hernia. Diaphragmatic hernia can be another cause of respiratory distress in a newborn. So if the diaphragm is not closed, so you all know that what is diaphragm and everything. So diaphragm separate the abdomen from the chest. Now, if there is an opening in the diaphragm, then what can happen? The abdominal content can go inside the chest. If abdominal content go into the chest, then there will be lack of space for lung, causing pulmonary hypoplasia, which is the cause of respiratory distress. What happens in these children is that they present with respiratory distress because abdominal content is now inside the chest. Abdomen will look very thin and scaphoid. And if you listen to the chest, you will see bowel sound. So you can hear some peristaltic gargling sound on the chest. When you see that or when you hear that, you know that this is likely to be a diaphragmatic hernia. At that time, you can do a X-ray, and if you do the X-ray chest, you will be able to see loop of bowel on the chest. So you can see over here, it affects the left side. So you can see all of these are bowel loop, which is what we call as diaphragmatic hernia. Okay. So the treatment is that this child will need intubation because otherwise the child will be having a respiratory distress. And eventually when it is a bit stable, then it will need a surgical repair. Now, omphalocele and gastroschisis. Are you guys with me so far? You are understanding? It is a bit different than what we discussed so far, and it is a bit difficult as well. But are you with me? You are understanding everything? Great. Moving on to omphalocele and gastroschisis. So, omphalocele is failure of intestine to return back to the abdominal cavity. So there will be the abdominal content will come out of the umbilicus, and if it is covered by a sac, you can see the sac, that is omphalocele. Whereas if abdominal content come out of the umbilicus, but there is no covering sac, that's called gastroschisis. Okay, very easy to diagnose, and both of them will need surgical repair. Now, up to that, we are good. Now we are moving on to a very important topic called neonatal jaundice. For neonatal jaundice, RCH has a good guideline. So I'll show you that. So go to this RCH guideline, which is jaundice in early infancy. Please make sure you read this thing. So it is good to know. So go through this guideline in your own time, but I will discuss most of the important things now. So jaundice means hyperbilirubinemia or excess bilirubin in the blood. To understand the pathophysiology of neonatal jaundice, you need to understand how this actually works. So let's talk a little bit. So what happens is that when RBC breaks down, then you have hemoglobin in it, right? So when hemoglobin breaks down, it produces heme and globin. And then the heme becomes biliverdin. Then from biliverdin, it becomes bilirubin. So up to this, it is unconjugated bilirubin. Then this unconjugated or indirect bilirubin will be taken by the hepatocyte. So there is a receptor in the like in the liver, and through this receptor, the unconjugated bilirubin will go inside the liver, and in the liver, by an enzyme, that unconjugated bilirubin will become a conjugated bilirubin. Okay? So when it becomes conjugated, that conjugated bilirubin or direct bilirubin will then go into the common bile duct. So you have got cystic duct, hepatic duct, and it becomes common bile duct. And through the common bile duct, it will go into the intestine or duodenum. Okay. Now through the duodenum or intestine, one part of it will come out through the feces as stercobilinogen, and some part of this will be reabsorbed through the gut into the blood, and it will go to the kidney and it will be excreted as urobilinogen. So that is how this whole bilirubin works, right? Now, the reason why I wanted to discuss this is that for you to understand the cause of it, you can't just memorize all of this. So if someone has got problem over here, like if someone has got their RBC is getting like the RBC is getting broken, like usually what happens every 3 months the RBC is supposed to get destroyed and new RBC should form. But if the RBC is getting broken much earlier, like let's say even within a month, RBC is getting broken. So if there is more and more RBCs getting destroyed, then there will be more and more hemoglobin, and that will cause more and more unconjugated bilirubin, such as if someone has got hemolysis. So it could be any kind of hemolysis, could be ABO incompatibility, could be RH isoimmunization, it could be, let's say, that any of the enzyme defect of the red blood cell, which is G6PD deficiency, hereditary spherocytosis. So all of those hemolysis will cause unconjugated hyperbilirubinemia. Okay. If there is any problem in this area, that will cause increased conjugated or direct bilirubin, such as if someone has got biliary atresia, like the common bile duct hasn't formed as it should be. So then bile cannot pass. So there will be more and more direct bilirubin in the blood. So direct bilirubin or conjugated hyperbilirubinemia is usually due to something blocking the bile duct, or there is total absence of the bile duct. So it could be biliary atresia, could be a cyst called choledochal cyst, which is blocking it, could be hepatitis. So if the hepatocyte is not working properly, so neonatal hepatitis. And then there is a hereditary condition called galactosemia that can be another cause of direct hyperbilirubinemia. So this is just basic. We will go into detail about all of this, but these are the main causes of unconjugated and conjugated hyperbilirubinemia. Okay, are you guys with me? Are you understanding the pathophysiology? So after intestine, so some of the bilirubin will come out as a stercobilinogen through the stool, and some will get absorbed into the blood, and then it will go to the kidney and then get out through the urine as urobilinogen. Moving on to bit of detail about pathological and physiological jaundice. So there are lots of types of jaundice. So we have got hemolytic jaundice, hepatocellular jaundice, and obstructive jaundice. We have got physiological jaundice, pathological jaundice. So the common one that we use for children or neonate is physiological and pathological jaundice. So physiological jaundice will never occur on the first day of life. So if jaundice appear on the second to third day, that's most of the time could be physiological jaundice, which means it just happens because the children liver is still immature, break down the bile and bilirubin easily. So that causes a bit of hyperbilirubinemia, which is common. But if a jaundice appear on the first day of life, that is pathological jaundice until you can prove otherwise. Physiological jaundice usually disappear by 7th day. So in a week, it usually starts to get better. And the peak bilirubin will be less than 13. And rate of bilirubin rise should be less than 5 per day. Now, these are not important for you to remember. Just remember, if jaundice appear on the first day of life, that's pathological jaundice. And if it is appearing after first day of life, then it could be physiological jaundice. And we should always consider pathological jaundice. One, that if the jaundice on the first day of life, if bilirubin rises more than 5 each day, if bilirubin more than 13, or direct bilirubin more than 2 at any time. So this is important. It will give you a very good idea that it is pathological or not. Okay, so if bilirubin more than 13, or it is increasing more than 5 every day, or if the direct bilirubin is more than 2 at any time, all of this will be termed as pathological jaundice. Okay. What are the causes of unconjugated hyperbilirubinemia? Causes of unconjugated hyperbilirubinemia, one of them could be physiological jaundice. So physiological jaundice is also unconjugated hyperbilirubinemia. So it is an exaggerated physiological response, usually should resolve, so completely resolve within 2 weeks in a term baby and 3 weeks in a preterm baby. There is a term called breast milk jaundice. So sometimes the child will have prolonged jaundice. So even after 2 to 3 weeks, still there is jaundice, and you can't find out any cause. And only thing that you can find out is that the child is having breastfeeding. So sometimes breast milk itself can cause a bit of hyperbilirubinemia, and that is what we call as breast milk jaundice. And this jaundice can continue for weeks and months. Okay, we will come to the discussion about it later on. So you have got physiological jaundice, breast milk jaundice. The other causes, so it could be sepsis, it could be hypothyroidism, hemolysis. So it could be ABO blood incompatibility or RH isoimmunization. It could be any of the hemolytic disease as we have discussed, like hereditary spherocytosis, D6PD deficiency, pyruvate kinase deficiency. So all of them will cause hemolysis. And other causes are not very important. You can go through that in your own time. So, but most important cause for unconjugated hyperbilirubinemia is hemolysis. So hemolysis can be ABO or RH. Okay. Now, if we think about unconjugated hyperbilirubinemia, the main finding will be that when you check the bilirubin will be very high. And when you check the unconjugated and conjugated bilirubin, you will see like mostly unconjugated bilirubin is high. So then you know it is unconjugated. If you get an unconjugated hyperbilirubinemia, before you think that it is physiological jaundice, you will have to rule out the other possibilities. So check for ABO, RH, those things. Check the thyroid, check the blood count for sepsis. So you will rule out everything, and then if everything is ruled out, then you will have either it is a physiological jaundice or it is a breast milk jaundice. But you know that physiological jaundice should not persist for more than 2 weeks. So if the jaundice persists for more than 2 weeks, then it will become breast milk jaundice. Okay? That's what you should think in your head, how to come to a diagnosis. Sunlight exposure is not a treatment of jaundice in child. So lot of parents, they just keep the child in sunlight and they have a very bad burn. So sunlight exposure is not a recommended treatment. Remember that. The main treatment is many times phototherapy. So if we get like the bilirubin is getting really high, then we can go for phototherapy for these children. So most of the kids will have a phototherapy and they usually get better with that. Few children might require exchange transfusion, which is not very commonly that we need to do. But if phototherapy itself is not helping, then the last option will be exchange transfusion. We will come to this treatment just in a bit. Now, let's discuss the mechanism of this jaundice so that you can understand why this is happening. So first of all, physiological jaundice. In children, apparently there is increased number of red blood cells. So in neonate, there is increased number of RBC. So if there is increased RBC, definitely there will be more and more bilirubin. So that's causing the physiological jaundice. On the top of that, their liver is not mature enough as well. Then increased hemolysis. So one can be ABO incompatibility. So ABO incompatibility is that if mother is O, and you know that blood group O has antibody against A and antibody against B, right? So if mother is O and baby is either A or B, what will happen that if there is a fetal-maternal transfusion, which is very common during the delivery time, so if mother bloods goes into the child blood, then mother blood will have antibody against the child blood. And that can cause hemolysis, that can cause this high bilirubin. So that's ABO incompatibility when mother blood is O and the child blood is either A or B. That's ABO incompatibility. And it is one of the most common cause of hemolysis in children. Then there is Rh negative or Rh isoimmunization. So all of you know about it. If mother is Rh negative and baby is Rh positive, that's the time this Rh isoimmunization will happen. Okay, I'm not going into the pathophysiology of Rh isoimmunization. We will discuss at some point. So that's the two causes of hemolysis. And if the hemolysis is there, then there will be a direct Coombs test. So if you do a direct Coombs test, this will be positive. Okay, so if you have got immune-mediated hemolysis, which is this Rh isoimmunization and ABO incompatibility, if you do a direct Coombs test, that will be positive. So that is one of the way to know. And then there is non-immune mediated hemolysis. So that's usually if the RBC is of different shape. So if normally RBC should be like this. But if RBC becomes spherical or elliptical, then spleen will think that this is a foreign body and it will just destroy the RBC more easily and more faster. So that's hereditary spherocytosis. And then there can be some enzyme defect like G6PD deficiency or pyruvate kinase deficiency. So all of these are causes of unconjugated hyperbilirubinemia. Okay. So bilirubin is bound to albumin and carried in the blood. But sometimes this carrying by the albumin can be disrupted if the child having infection like neonatal sepsis or having hypoxia. So that can also cause a bit of unconjugated hyperbilirubinemia. So you know that bilirubin will be transported to the hepatocyte, and within the hepatocyte by a enzyme which is what we call as glucuronide. So using the glucuronyl transferase, which is the GT, so using this glucuronyl transferase, unconjugated bilirubin will become conjugated bilirubin. What if there is a decreased activity of this enzyme? Then the unconjugated bilirubin cannot become conjugated, right? So then again, unconjugated bilirubin can be high. And that can be found in few cases, like if there is a condition called Crigler-Najjar syndrome, where the child doesn't have this enzyme at all. So there is a hereditary condition where there is no GT at all. Okay, so that can also give you unconjugated hyperbilirubinemia. Next, so far we know about unconjugated bilirubin and how it causes jaundice. Then let's say that the patient has got enough GT enzyme and unconjugated bilirubin has become conjugated. Once it becomes conjugated, Anything after that, if there is any problem, it will give conjugated hyperbilirubinemia, such as biliary atresia, where there is absence or fibrosis of the biliary tract. If there is lack of biliary tract, then conjugated bilirubin cannot be transported to the intestine. So there will be increased conjugated bilirubin. Most of these patients presents in first 2 weeks life with jaundice, poor feeding, vomiting, lethargy, hepatosplenomegaly, and a dark urine with pale stool. So dark urine, pale stool is a very important finding for obstruction or something wrong in the biliary tract. So dark urine, pale stool, hepatosplenomegaly, and then there is progressive jaundice, that is biliary atresia. The way to diagnose this condition is ultrasound. So you'll have to do an ultrasound and that will be able to confirm the diagnosis. If you want to confirm the diagnosis, it can be done by liver biopsy. But most of the time, ultrasound is enough to diagnose. So initial test is ultrasound. Confirmatory test is percutaneous liver biopsy. The initial treatment is hepatic portojejunostomy. So we just make a bypass so that the bile can be transported. Okay, so from portal vein, you just bypass it to jejunum so that from portal vein it can go directly to the jejunum. Okay, so portojejunostomy will be the like initial treatment, but long-term treatment is liver transplant. Okay, so that's biliary atresia. Apart from that, conjugated bilirubinemia can be due to other causes, like conjugated bilirubin can be due to sepsis, can be due to hypothyroidism, galactosemia, choledochal cyst, biliary atresia, and then there are some hereditary causes like Dubin-Johnson or Rotor syndrome. Okay, so these are the causes of direct hyperbilirubinemia. Now, this chart is very good to give a good idea about what we have discussed so far. So if you have got a patient who you think that it is a pathological jaundice, first thing you find out is that is it direct or indirect hyperbilirubinemia. If it is direct, then you just have very small things to rule out. So if you think it is choledochal cyst, biliary atresia, then you will just do an ultrasound. If you think galactosemia, then you will do some test for it. Hypothyroidism, you will do a thyroid function. Sepsis, you will do a blood test. It's not very hard to diagnose the cause of direct hyperbilirubinemia. But if it is indirect hyperbilirubin, then you do the Coombs test. If Coombs positive, then it is either ABO incompatibility or RH incompatibility. If it is Coombs negative, then you know that it can be a lot of other conditions. So it could be spherocytosis, G6PD, pyruvate kinase, cephalohematoma, Crigler-Najjar or Gilbert syndrome. It could be even polycythemia. So that's how you will come to a conclusion that what could be the cause of neonatal jaundice. Not all of these are important for exam. The important ones we will discuss. Okay. So far, everyone clear? Great. Moving on. Breast milk jaundice versus breastfeeding jaundice. So breast milk jaundice, you have got an idea that breast milk jaundice occurs due to glucuronidase present in some breast milk. Infant become jaundice in the first 2 weeks of life, and it can persist for even 2 to 3 months. And sometimes you might need to do even phototherapy if needed. But children do not need to stop breastfeeding because of that. So it will get better. So that's breast milk jaundice, which mainly happens due to a enzyme presenting in some of the breast milk. What is breastfeeding jaundice? Breastfeeding jaundice means that if the child is not getting enough breast milk, so it means that baby is not nursing well and not getting many calories. This is common in first-time breastfeeding mothers. The infant may become dehydrated. However, it is lack of calories which causes the jaundice. So most of the time, at first-time mother, they are not aware of like the child is not getting enough breast milk. So the child gets like loss of weight, loss of calories, and that causes the jaundice. The treatment is obtain a lactational consultation so that the mother understands how to breastfeed the baby and then rehydrate the baby. Okay, so there is difference between breast milk jaundice and breastfeeding jaundice. Next, what is the treatment of hyperbilirubinemia? So as we discussed that the main treatment, especially if it is unconjugated hyperbilirubin, we will start with phototherapy. There is a indication of what we normally do. So this is the chart called bilirubin nomogram. So we use this nomogram to decide what kind of treatment the child will need based on their age and also their bilirubin level. Okay, so let's say, so you can see that time after birth is on the x-axis and on the y-axis you have got serum bilirubin level in millimole per liter. If you look over here, let's say that a 24-hour-old baby if their bilirubin is like this. Now, as you can see that as the time goes, we can tolerate more and more bilirubin to start the phototherapy. For a 24-hour-old, they will get phototherapy if the bilirubin is above 250, right? But for a 72-hour-old baby, they will require phototherapy if it is in between 300 to 350. Okay? In the same way, when exchange transfusion will require, if a 24-hour-old, even after giving phototherapy, their bilirubin is now at this stage between 300 to 350, then we will move on to exchange transfusion. So we use this nomogram to decide what we are going to do. You don't need to memorize this nomogram. All you need to remember, they usually don't bother you too much about this because you need the nomogram to decide, and everyone just have a look on their phone and then they decide. So, but get a basic idea about what's the indication of phototherapy for a 24-hour-old and what's the indication for 48-hour and 72-hour. Just write it in somewhere that which level you will go for photo and which level you will go for exchange. Okay, making sense, guys? This nomogram. Okay. Now this is from RCH about jaundice in the newborn, step-by-step approach. So if a newborn is jaundiced, first thing we look at is the child unwell or febrile. Because if it is a febrile child having jaundice, we need to rule out septicemia. So we will go for a septic screening at that time. If the child is not febrile, then we check the bilirubin level. So we check the total bilirubin, unconjugated and conjugated bilirubin level. If the conjugated bilirubin more than 15% of total, this is a very important thing. If the conjugated bilirubin or direct bilirubin more than 15% of the total bilirubin, then you will think that this is a conjugated hyperbilirubinemia. At that time, you will be checking for direct hyperbilirubin. So for neonatal hepatitis, you will check the liver function test. For hypothyroidism, thyroid function, septic screening, viral serology for neonatal hepatitis, and an abdominal ultrasound to rule out choledochal cyst and biliary atresia. So you'll be doing all the tests to rule out conjugated bilirubin cause. If conjugated bilirubin is not more than 15%, then it is likely to be unconjugated bilirubinemia. So then one by one, you will do all the tests. So you'll do a Coombs test to find out if it is like immune mediated or non-immune mediated. If Coombs is positive, then it is either ABO incompatibility or RH isoimmunization. Okay, if the Coombs is negative, then it could be any of the others that we discussed. Okay, so that's the basic of all the discussion that we have done so far. Hope that you have got a bit of idea. Which one is more problematic, unconjugated or conjugated? For a child, unconjugated bilirubin can be a neurological poison because this can go, or this can actually go through the blood-brain barrier. So unconjugated bilirubin can go into the brain, and it can cause the irreversible brain damage known as kernicterus. So that's why unconjugated bilirubin can be very serious for a child. Moving on to some of the common causes. So ABO incompatibility, as we discussed, it is mainly caused by mother group O and child either A or B. If we suspect something like that, then we do a direct home test on infant. And phototherapy is required immediately for this patient. Breast milk jaundice, if you removed all the causes of prolonged jaundice, then the only cause that is left is breast milk jaundice, and you will get unconjugated hyperbilirubinemia. So it starts around the 4th day of life, so late in the first week, peak at 3 to 4 weeks, and stay for 2 to 3 months. Diagnosis is confirmed by suspending, not stopping breastfeeding for 24 to 48 hours. Now, you can do that if you are not sure, then you can just ask the mother to suspend the breastfeeding for 24 to 48 hours and then see if the jaundice is getting better. But it is not always needed because the breastfeeding is very important for a child. So just because a child has got breast milk jaundice, we don't need to stop. So breastfeeding will be continued, and there is no recommendation of changing to formula milk for this. It will get better by its own. So that's all about neonatal jaundice, guys. Any question? Are you with me so far? So let's say that if we go to the nomogram, if a 24-hour-old having 400, so 400 around this, right? Still, we will start phototherapy. Only time we will go for both exchange and phototherapy if it is like 425. But most of the time, phototherapy will be started first. But if it is really high, like a 24-hour-old having, let's say, 500, that will require exchange transfusion without any doubt. No, we don't need to detail. We don't need to go to the detail of anything that we are not discussing. Okay? If anything you need, we will discuss it. And as I said that all of you need to write your name to join the classes. Still, I can see that one of you who has written, do we need to read the detail of exchange transfusion? Your name is still Samsung. So we will not allow anyone to continue the classes without their name. Okay. And I always write it in the, when we post it in the Zoom, in the Facebook group, that you need to write your name. Still, I can see many of your name is not here. We will give you the break time to change your name. If you don't change your name within then, we will remove you from the group or from this class. Okay, and then unfortunately you will not be able to rejoin. So please make sure you change your name so that we know who you are. So I can see still that one of your name is Redmi Note 8. So I'm just writing you to change your name. Okay. So that's all about neonatal jaundice. Now we are moving on to torch infection, which is transplacental intrauterine infection. So these are the infections which can transmit from the mother to the baby. So one of them is toxoplasmosis. So it is a maternal infection, usually comes from ingestion of undercooked or raw meat. And it comes from the infected cat. Especially we ask the pregnant mother not to change or clean cat litter, because most of the time it comes from the infected cat's stool. So handling the cat is usually not a good idea during the pregnancy time. Or it can also come from undercooked meats or raw meats. So children usually presents with lots of finding. All you need to remember that most of these torch infection will have jaundice, hepatosplenomegaly. They can have microcephaly, chorioretinitis. They can have intracranial calcification or seizure. It doesn't come in exam that much, so it's not most important thing. Just to give it a read. But congenital rubella is very important. So if mother gets contacted with rubella, and if the mother gets contacted in the first trimester, the risk of having a congenital rubella syndrome baby is 80 to 85%. So almost all of them will get it. And congenital rubella syndrome, the baby will have cardiac defect, most importantly, patent ductus arteriosus. They can have cataract, congenital deafness, hepatosplenomegaly, and a kind of a rash called blueberry muffin spot. So it's not the best thing to get because hearing loss, cataract, heart defect, so all of these can cripple the child. So there is congenital rubella syndrome. Cytomegalovirus. It is the most common transplacental infection. So cytomegalovirus infection, it can happen anywhere. So it's a virus, you can get it from anywhere, but it's common in patient who works in renal unit where there is lots of like transplant patients or patient who is on chemotherapy. So like immune suppressed patients, if the pregnant mother takes care of them, then there is high risk. So cytomegalovirus also presents with hepatosplenomegaly, jaundice, IUGR, microcephaly, chorioretinitis, and they can also get sensory neural deafness. How to confirm cytomegalovirus in a child? Either you can take the blood and check the cytomegalovirus serology, or you can also check the urine for cytomegalovirus antigen. So any of these two will be able to diagnose CMV in a child. Okay. So what actually happens, because all of the symptoms are pretty much same. So if any child having hepatosplenomegaly, chorioretinitis, microcephaly, So they will be tested for all of these, like torch infection. Okay? So just remember this. So rubella will have triad of cataract, deafness, and heart defect. CMV will have microcephaly with periventricular calcification, and toxo will have hydrocephalus with calcification. So that's the only three things that you need to remember. Others, no need. So CMV, you can do a CMV serology from the blood, or you can do a CMV urinary antigen. Okay. All right. So that's more or less the newborn thing that we wanted to discuss. We'll take a 10-minute break now, and we'll go into cardiovascular system for pediatrics. Okay. Thank you all. 10 minutes. All right, everyone, let's start again. So now we are starting with cardiovascular system for pediatrics. So have a look on the cardiovascular system. So this is the fetal circulation. More or less everything is same, but you can see that there is two things which we don't have. So foramen ovale. So foramen ovale is kind of a defect in between the two atrium, which just makes sure there is like a exchange of blood in the fetal heart. So there is foramen ovale, which is supposed to be closed after birth. And then you can see ductus arteriosus. So you can see that this is the aorta, right? And that's the pulmonary artery. Pulmonary artery gets connected with the aorta by this ductus arteriosus. And also after birth, this ductus arteriosus will be closed. Okay. So these are the two things that you can see. And then there is ductus venosus, which is not important for now. So these three things are there in fetal circulation, which is not there after birth. So pediatric cardiology is difficult and it's a bit complex than the adult cardiology, but we will make sure that you understand each and everything of it. And only thing that you need to know will be discussed. So first of all, left to right shunt cardiac defect. Or you can say that these are non-cyanotic congenital heart disease. So the common causes of non-cyanotic congenital heart disease are ASD, VSD, and pedia. The most common congenital heart lesion is ventricular septal defect. And ventricular septal defect means that, so you can understand it. So this is the heart, and then this is the interventricular septum, right? Now, if there is a gap in the septum, then blood can come from the left side to the right side. Blood always comes from the high pressure area to the low pressure area. So because left ventricle has got high pressure, blood initially will follow from left side to right side. Okay? So that's why we call it left to right shunt in VSD. But at some point, what can happen that more and more blood is coming into the right side, and right side is getting more and more blood pressure. Okay? At some point, right ventricle will start to get thickened to pump this blood to the pulmonary artery. And at some point, there will be more blood pressure on the right side than the left side. So it takes years to have it. And then the shunt will be reversed. So at some point when right ventricle will have more pressure than left ventricle, blood will then bypass. So blood will then go from right ventricle to left ventricle. Now you know that right ventricle gets all the deoxygenated blood from the body. So all the carbon dioxide blood. So what will happen with this right to left shunt is that now the deoxygenated blood can go to the left ventricle with this shunt. And from left ventricle, deoxygenated blood now can go through the aorta into the whole body. And deoxygenated blood can cause cyanosis. So this is what we call as Eisenmenger syndrome, where the shunt is reversed. So initially it will be left to right shunt, but at some point the shunt will be reversed, and then deoxygenated blood can go into the whole body. Is it making sense for everyone? Okay, so still few of you are having difficulty. So So ventricular septal defect means there is a defect in the ventricular septum. So initially blood will come from the left heart to the right heart. So it is called left to right shunt. But at some point, because more and more blood coming to the right side of the heart, right-sided pressure will be higher than left side. So what will happen then? Blood will then go from the right side to the left side. So this is called right to left shunt. So that means the shunt has reversed. The problem with the shunt reversal is that now blood, which is deoxygenated blood, coming from the whole body, is now going directly to the left ventricle. And when it goes directly to the left ventricle, from left ventricle, it can go through the aorta into the whole body. And deoxygenated blood is what causes cyanosis. Okay, so the main problem with this shunt reversal is that the child will become cyanotic and short of breath. Okay. Is this clear for everyone now? Good. So, because this ventricular septal defect, because there is a lot of like the blood is moving in and around, like in and out of the ventricles. If it is a small defect, it might not cause any problem. So if it is small defect, it will be asymptomatic. But if it is a large defect, the children can have features of heart failure, which means shortness of breath, feeding difficulties, poor growth, sweating, especially during feeding, and also features of heart failure. So shortness of breath, getting cyanotic, especially if there is shunt reversal, feeding difficulties, playing, like when they go for playing, they get short of breath quite easily. So those will be the sign or symptom for any kind of congenital heart defect. And for VSD, you can get a murmur. So the murmur that we get for VSD is called pansystolic or holosystolic murmur over the left lower sternal border. So remember the holosystolic murmur for VSD. Diagnosis. So initially you can do a chest X-ray and the ECG, but confirmatory test is echocardiogram. Treatment for a small VSD, it usually can get closed by itself in the first 1 to 2 years. But if it is like it's a large one and child is symptomatic, then it will require surgical repair. If shunt is bidirectional, there will be some blood which will be deoxygenated, some blood will be oxygenated. So there will be less cyanosis than when there is like right to left shunt. But there would be a bit of cyanosis in that child as well, but less. ASD. So ASD is the second common congenital heart disease. The symptoms will be exactly same like VSD. Only way to differentiate it is the murmur. So with hemodynamically significant lesion, if it is a large ASD, you can get two murmur. One murmur is systolic murmur, which is ejection systolic murmur, which is the main murmur of ASD. So VSD is holosystolic murmur and ASD is ejection systolic murmur. But if it is very large murmur, ASD can also give you a diastolic rumble. Okay, so you can get two murmur, but the main murmur for ASD is ejection systolic murmur. The diagnosis is same, so you can do a chest X-ray and ECG, but echocardiogram is definitive. Most of the time, it get closed spontaneously. But if it is large or symptomatic child, then surgical repair is needed. So management usually doesn't come in exam. All they want you to know that how to diagnose this. Next, patent ductus arteriosus or PDA. So you know about the ductus arteriosus now. So ductus arteriosus is that one which connects the fetal pulmonary artery with the aorta, right? So if this is the heart, and that we have got aorta, and that's the pulmonary artery. Ductus arteriosus connect the pulmonary artery with the aorta, right? So if this ductus arteriosus doesn't get closed after birth, that is called PDA, patent ductus arteriosus. Common in children with rubella infection or premature babies. If it is small, it might not cause any symptom. But if it is large, the symptom will be heart failure symptom. So shortness of breath, feeding difficulty, exercise intolerance, everything. Other than that, you can also get a continuous machinery murmur for PDA patient. Okay, you can get wide pulse pressure and bounding arterial pulses. Now these are not very important to remember. Just remember this continuous machinery murmur for PDA. Investigation is same. So you do a chest X-ray, ECG, and to confirm the diagnosis, you have to do a echocardiogram. Treatment. It can get closed spontaneously if it is a small. So asymptomatic small PDA, no need of any treatment. But if it is not getting closed, especially for preterm baby, you can give them indomethacin. So prostaglandin inhibitor. So prostaglandin inhibitor can close the ductus arteriosus. So what happens is that prostaglandin is supposed to keep the ductus arteriosus open in fetus. So if you want to close the prostaglandin, or if you want to close the ductus arteriosus, you have to inhibit the prostaglandin. So that's why you are giving prostaglandin inhibitor, which is indomethacin. Okay, so indomethacin is one of the medication which can be given to close the ductus arteriosus. Still not getting closed and it is big and symptomatic, then you will need to surgical repair. Okay, so that's PDA. So all of these are left to right shunt, which means that even for ductus arteriosus, blood will come from the left side to right side. That means from aorta to the pulmonary artery. Okay. So these are your left to right shunt causes. Any question with these three conditions? Symptoms are same. So breathing difficulty, shortness of breath or exertion, especially exercise intolerance, features of heart failure, all of the same symptom. ASD murmur is ejection systolic murmur, and if it is significantly large, then you can get also a diastolic rumble or diastolic murmur. So why we give indomethacin in PDA? So ductus arteriosus, to keep the ductus arteriosus open, you need prostaglandin. And that's how the baby's or fetal ductus arteriosus is open. But after birth, this ductus arteriosus needs to be closed. So if you can give something which can inhibit the prostaglandin, that will do the job. So indomethacin is something which can inhibit the prostaglandin. So that's how we can at least help to close this ductus arteriosus. Okay. Coarctation of aorta. So now coarctation of aorta is a lot to learn, but we are not going to discuss all of this. The basic is all that you need. So coarctation of aorta means aorta is narrowed at some point. So most of the time, coarctation of aorta or the narrow area is just distal to this left subclavian artery. So this is the left subclavian artery. Just distal to that is the narrowed area on the aorta. And that is what we call as coarctation of aorta. Now you understand from here that what's the main problem with this is that this part, that means proximal to the narrowed area, there is more and more blood, right? Because obviously this is narrowed, so more and more blood in this area. So blood will flow more to the upper extremity. So you have got left subclavian artery which supply the upper extremity, right? So especially the left arm. So there will be more and more blood supply to the upper extremity, but you can see that less blood flow to the lower extremity. So sometimes in coarctation of aorta, if you check their blood pressure, you will see a marked discrepancy between their upper extremity and lower extremity blood pressure. But normally, upper extremity blood pressure is less than the lower extremity blood pressure. But that will be reversed in coarctation. So in coarctation, upper extremity, that means upper arm blood pressure, will be higher than lower leg blood pressure. Okay? So that's one of the main findings. So let's see what happens. So increased blood pressure in vessels proximal to the coarctation and decreased blood pressure below the constriction. That's we understand. So what will happen? In this case, radiofemoral delay will happen. So radial artery is upper extremity and femoral artery is lower extremity. So that now you understand from where this radiofemoral delay comes, right? Because now more blood going to the radial artery than femoral artery. So if you check radial and femoral artery at the same time, you'll see a delay there. So one of the common finding is radiofemoral delay. Okay. Then normally leg systolic blood pressure is 10 to 20 millimeter higher than the arm. But in coarctation, that will be reversed. So leg pressure will be reduced. And sometimes even right and left arm blood pressure can be different. So you can get more blood pressure on the left arm than the right arm. Sometimes we also see one other thing is that we call it differential cyanosis. So because there is a lot of blood on the upper extremity, upper part of the body looks very pink because lots of blood supply, especially in children. And lower part of the body looks less red, or sometimes even it becomes cyanotic. That's why we call it differential cyanosis, where some part of the body is cyanotic and some part is pinkish. Okay, can be found in this coarctation as well. So diagnosis, you can do a chest X-ray, and sometimes, especially in adult, you can get a notching of the inferior border of the rib. So you can see that these are the ribs. So there is a bit of notching on the inferior border that can be found in coarctation. But most importantly, you have to do an echocardiogram to diagnose it. Treatment. If it is a neonate, what will you do for coarctation of aorta? You will give prostaglandin infusion to maintain the patent ductus, which establish adequate lower extremity blood flow. So what you do in this case in infant, so in infant, you will keep the ductus arteriosus open. So if you can keep the ductus arteriosus open, then at least some blood flow will be there. So sometimes what will happen in this case that if we can keep this, so blood will flow in and out of this left left artery, so like aorta and the pulmonary artery. So basically what we are trying to do is that, because especially in infant, they might not get enough blood in their lower extremity, especially for the severe coarctation. So if we can keep this pedia open, then there will be some kind of blood flow, at least few bloods or few amount of blood will flow from this pulmonary artery to the aorta. Even though it will become a cyanotic blood, but still there will be a little bit of blood flow. Rather, like it's better to have a little bit of blood flow rather than no blood flow at all. So that's the idea. Okay. So for neonate, we would like to keep the PDA open. And if we want to keep the ductus arteriosus open, we can give prostaglandin. So now you will be giving prostaglandin infusion to keep the ductus arteriosus patent. And then once the child is a bit stable, then we go for surgery. Okay, but surgery is the main treatment. PDA closes just after birth. So usually within 1 to 2 days after birth, PDA will be closed. Clear everyone about the coarctation of aorta? Good. Now, so until now, we have discussed all about the acyanotic heart disease. But now we are going for cyanotic heart diseases in children. So cyanotic heart diseases are Fallot's tetralogy, transposition of great vessels, truncus arteriosus, total anomalous pulmonary venous return, and tricuspid atresia. The only thing that we are discussing today is these two. You can just remember the name of it, but not needed for the exam. So Fallot's tetralogy, you have heard about it, I'm sure. So Fallot's tetralogy is one of the commonest cause of cyanotic heart disease in a child. So what happens? Tetralogy, right? So 4 things. So for Fallot's tetralogy, first thing is there will be a VSD. So you can see there is a VSD here. So ventricular septal defect. Just on the top of VSD, there will be an overriding aorta. So aorta will be just above this VSD. Then there will be pulmonary stenosis. So this is the pulmonary valve. And you can see the pulmonary valve is very narrow. So pulmonary stenosis. And fourth, because of pulmonary stenosis, your right heart needs to work very hard to push the blood. So there will be right ventricular hypertrophy. So these are the four components of Fallot's tetralogy. So VSD, overriding aorta, pulmonary stenosis, and RVH, right ventricular hypertrophy. So it is the most common cyanotic lesion in children. The main features for this is cyanosis, right? So child will become cyanotic, especially with exertion. So if the question says that after playing, the child suddenly becomes short of breath and cyanotic, we would be thinking about it. So children will become cyanotic, can have marked clubbing, have dyspnea on exertion. So that's the main features. Okay. There is sometimes these children can get a paroxysmal hypercyanotic attacks. So many times what can happen, child is playing and doing a lot of exertion. Suddenly child become dyspneic and increasingly cyanotic, gasping for air, and sometimes even can lose consciousness. It is called paroxysmal hypercyanotic attack. For such attack in tetralogy of Fallot, we put the child in a knee chest position, give oxygen, morphine, and beta blockers. So that's the treatment for tetanus spells. If you do a physical examination for phallus tetralogy, few things you can get is harsh systolic ejection murmur. So that's one of the murmur you can get in this case, but it's not very common to get murmur in these children. The main finding is cyanosis and clubbing. Okay, so how to diagnose this? So if a child coming to you, if you look over this question, a 6-month-old child is prone to episodes of restlessness, cyanosis, and gasping. Symptoms will resolve with knee chest position. Why knee chest position helps this kind of children? Because when you put it like a knee chest, you increase the vascular resistance. You increase the systemic vascular resistance, which means that it is hard for the heart to send the cyanotic blood into the aorta. So you're just increasing pressure over here by doing the knee chest position. Okay? Because through this VSD, blood, like cyanotic blood, can easily go into the aorta. So if you can increase the pressure over here, then blood will not flow very fast. So that way you can decrease the flow of cyanotic blood. Okay, that's the idea of knee chest position. And physical examination shows an underweight infant, so they will have poor weight gain and a harsh systolic ejection murmur. Okay, so that's the finding for TOF, or tetralogy of Fallot. So diagnosis, you will start with a chest X-ray. You can get a boot-shaped heart in this patient. It looks like this. See the boot-shaped heart? So that's one of the finding of Fallot tetralogy. And echo is the gold standard for diagnosing this. Treatment. If child is cyanotic at birth, so it's not always common that Fallot tetralogy will present at birth. Sometimes it can present even like child is 3 months, 6 months at that time. But some children can even present after birth. Okay. So if the child is cyanotic at birth, we say that we will try to keep the prostaglandin infusion so that the PDA or the ductus arteriosus doesn't get closed. So we will also try to keep the ductus arteriosus patent in this case for children. Okay. Why? Because if you can keep it open, the cyanotic blood that's going directly to the aorta, they can come back to the pulmonary artery, and then it can go to the lungs and can get oxygenated. That's the idea of keeping the PDA open, or to keep the ductus arteriosus open. Okay? Making sense, guys? It is not complicated if you really understand how heart works. All good for everyone? Okay. So prostaglandin infusion for neonate, and basically this will need a surgical repair. That's it. That's the treatment. So benefit of ductus arteriosus open is that, so you can see that through the VSD, cyanotic blood can directly go from the right heart to the aorta, right? Because you can see that it is an overriding aorta. So some blood can go directly to the aorta from here, and there is a cyanotic blood or deoxygenated blood. So if you can keep the ductus arteriosus open, then some of the deoxygenated blood will come back to the pulmonary artery. And you know that from pulmonary artery, blood goes to the lungs, right? Now, this is the time you, like any of you who are having difficulty to understand it, is that you might have missed our first class on cardiology, because we discussed this pathophysiology in a very nice way. So what happens is that the deoxygenated blood will come to pulmonary artery, and then from pulmonary artery it will go to the lungs, get oxygenated, and then from pulmonary vein it will come back to the left atrium. So then it will become oxygenated. So what you are doing with ductus arteriosus open, you're actually you're you're trying the body to make the deoxygenated blood oxygenated. That's it. It's just a way of making the cyanotic blood oxygenated by this bypass. Okay. Next, TGA, transposition of the great arteries. It is the most common cyanotic lesion present in the immediate newborn period. So within 24 hours after birth, if a child having cyanosis, we would think of TGA. So great arteries means pulmonary artery and aorta. These are the two great arteries. And we know that pulmonary artery, so we know that aorta should come from the left heart, and pulmonary artery will come from the right heart. But if they change their position, such as pulmonary artery arising from the left heart and aorta arising from the right heart, that's called transposition of great arteries. What is the problem with this, guys? The problem is that now aorta is arising from the right heart. And you know the right heart has got all the deoxygenated blood. So now deoxygenated blood, it's just directly going to the body. Okay, so that is very bad for the baby, and baby can die, right? So that is the problem, because deoxygenated blood going directly to the aorta. So that's the main problem with TGA. So the only way the child can survive is that there is a PDA available. So there is the ductus arteriosus open, which will cause some mixing, and if there is a VSD. So the child needs something open so that the blood can mix together. So only way the child will survive is that if the ductus arteriosus is open and by any chance child has got a VSD. Okay. So clinical presentation, the main presentation is immediately after delivery, child will be quite cyanotic. And other than that, if a VSD is present, you can get a murmur of VSD as well. But the way to diagnose is echocardiogram. Treatment, you have to keep the PDA open. So we give prostaglandin, and basically this child will need a arterial switch surgery. That means they will change the position of aorta and pulmonary artery. So this is the surgery which can save the child. Okay, so that's TGA. Next is hypoplastic left heart syndrome. So hypoplastic left heart syndrome is also important for exam. It means that you can see that this is the normal heart. Left heart is the main strong part. But the hypoplastic left heart syndrome means that you can see that this is the left ventricle. So when there is a small hypoplastic left ventricle, that's the time we will call it hypoplastic left heart syndrome. So in this case, the right heart takes all the effort. So hypoplastic left heart means atresia of the mitral and aortic valve, left ventricle and the ascending aorta. Right ventricle will maintain both pulmonary and systemic circulation. And again, For this kind of children, they will have a foramen oval to mix the blood. So there will be something which will keep the baby alive. So most of the time there will be a ASD, so atrial septal defect, or a foramen oval, through which there will be mixture of blood. Okay. And obviously we'll need to keep the ductus arteriosus open as well. So what we normally want in this case, that usually we say by the time child becomes 4 days of life, then if you don't open the ductus arteriosus, then by the time it is 3 to 4 days, eventually ductus arteriosus will be closed. And that's the time usually this kind of children will start to have problems. So they will have cyanosis, breathing difficulty, tachypnea. Okay, so all of the feature will come up between the 3 to 4 days of life. But the way to survive is that if we can keep the ductus arteriosus open, because now everything is maintained by the right heart. Right heart has got more pressure. So what will happen, that there will be shunt. So if you can keep the ductus arteriosus open, then blood from the pulmonary artery will go to the aorta and it will mix up together and it will go to the whole body. Okay. Otherwise, because aorta is not very active at the moment, so that's why they need some blood. So the only way to get the blood is if there is a connection between left atrium and right atrium, and if there is a connection between pulmonary artery and aorta. So this two is needed for survival. But at some point, this will need a surgical repair. But the problem is that you might not be able to do anything for this kind of cases. The main treatment might be just a cardiac transplantation. Okay. So that's hypoplastic left heart syndrome. Now to summarize your cyanotic heart disease, you have got Fallot's tetralogy. Fallot's tetralogy is the most common cyanotic heart disease in a child. And this kind of children usually presents in 3 to 6 months of time with exercise intolerance, cyanotic, and sometimes even they can get those status spell. Right? And main treatment for neonate, you need to keep the ductus arteriosus open and surgical repair. For transposition of great arteries, it is mainly evident in the first day of life. So cyanosis in the first day of life. And cyanosis at 3 to 4 days of life, that is most likely hypoplastic left heart. Okay. That's all about our today's class. Okay. And I hope that you got a bit of understanding about these pediatric topics. We will just recapitulate what we have learned today, and let's see if you can understand something that we have discussed. So let's say you have got a child who has got jaundice in the first day of life. So you know that it is pathological jaundice. Then you tested conjugated and unconjugated bilirubin. You found unconjugated bilirubin is very high. Then you do a Coombs test and you get it positive. What's your most likely causes for Coombs test positive? Yes. So either it is a ABO incompatibility or it is RH. Very good. Jaundice in the second week, unconjugated, child is well, and you have done everything, still you can't find out any problem. What's the diagnosis? Breast milk jaundice. Good. Jaundice on 4th day of life, but conjugated bilirubinemia, dark urine, pale stool. Biliary atresia is the likely cause or obstructive cause. So for biliary atresia, what will be your next investigation? Ultrasound of the abdomen. Good. A child born 2 days ago, now cyanotic, you have given oxygen, but no improvement. What's the likely diagnosis? Yes, so TGA is the one condition which does not get better with oxygen. Because even if you give oxygen, the problem is that the artery is switched. So if it is first day or second day, cyanotic baby, but not getting improved with oxygen, then we think of TGA. Fourth day of life, cyanosis, respiratory distress. Now, it is very hard to just say it is hypoplastic, but just keep in mind that it could be hypoplastic left heart syndrome. In hypoplastic left heart syndrome, you will get right ventricular hypertrophy as well because right heart is taking over. 3-month-old child, feeding difficulty, poor weight gain, harsh pansystolic murmur. What's it? It can be any of them. So 3-month-old, poor weight gain and murmur. Did the child have cyanosis? No. If it is not cyanosic, it's not TOF. So harsh pansystolic murmur is VSD. Same patient having ejection systolic murmur, that's ASD. Okay, so remember one thing. To diagnose TOF, you need cyanosis. Murmur may or may not be there. Okay, so if there is cyanosis, then you only think of TOF. Otherwise, just for a murmur like this, it will be VSD or ASD. Child 6-month-old, respiratory distress, femoral pulse absent, cyanosis in lower leg. Yeah, so that's coarctation of aorta. And it's in coarctation, it's not ejection systolic murmur, it is the you can get sometimes, yes, we can get it, but for coarctation, it is mainly we will look into this radiofemoral delay, we look into the differential cyanosis, those are main findings. Okay, but for a child who is having poor weight gain and ejection systolic murmur, we will mainly think of ASD. Last question for today before we finish. Yes, there will be radio, it can be radio delay also in coarctation. Innocent murmur. There is a term called innocent murmur which comes in exam a lot. So innocent murmur can be diagnosed in children over 12 months of age if any of the 4 criteria are met. So no other abnormal physical finding, child is asymptomatic, no risk factor for structural heart disease, and the auscultatory finding fulfills the 7S. So 7S means it is a sensitive murmur, so it changes with child's position or respiration. It's short, it's never hollow systolic murmur. It is single without any clicks or gallops. It is a small, so murmur will be limited to a small area, not the whole precordium. It is soft, sweet, which means it is not harsh, and it is always systole. Okay, so only time you can diagnose innocent murmur if it is more than 12 months. It's a small area of murmur which is systolic, soft, changes with respiration or position. Then otherwise you can't. Okay. For innocent murmur, most of the time you don't need to do anything. You can reassure the parent. But if you are not sure that it is an innocent murmur or not, it is better to send the child to a pediatric cardiologist for a review. You can do an echocardiogram also, but many times echo cannot be done in outpatient area, especially for infant or for children. So you might just need to send them for a pediatric cardiologist review. Okay, so that's innocent murmur. So that's all about today's class. Our next class will start with childhood infection. And if you get some time in between, which you will not get, but if you have some time, you can start childhood infection from JAM chapter 86, which is very important chapter for your exam. So we will start from childhood infection and then we will move forward. Okay? No, fever murmur is a systolic flow murmur. It's not innocent murmur. Remember, one of the criteria is child should be asymptomatic. So if it is fever, it is symptomatic, right? All right, any question, guys? So are you getting well with our course? Are you understanding everything? You have got study partners solving some questions and everything? The videos, I'm sorry we can't upload earlier than what we are doing, Dr. Omar. It takes some time because especially for our mentors, they take the class at night and then they send it in the morning or in the afternoon or sometimes even in the evening after they come back from their work. So, and then we can upload them. So at least it takes 1 to 2 days to upload them. Yes, so the study material is already available in the portal.
Yeah, but please, can we be getting the lectures at least a bit earlier? Because some of us have difficulty following the live class because of the timing. I'm currently working whilst I try to follow. So if I'm able to get it within 24 hours, I can then sit on it before the next class.
As I said, Dr. Omar, it takes at least 2 to 3 days to upload any kind of class. We can't do it before that. It takes some time. Okay? Because these are very like large videos. It takes time to upload and then to add to the portal. It's take a little bit of time. But we can't do it like immediately. That's not possible. The question banks, you can find it in your Facebook course group, which is named as MCQ Batch 10. And if you go to the featured section, or even you can search it, then you should be able to find it. So go to the featured section of the group and scroll down, you will see a link for QBank. And Dr. Sundar's class schedule is given also to the portal. I'm not sure what's there at the moment. So class schedule 5th and 9th. So no, there is no class before 9. Yes, so read the lecture note because for pediatrics, I have added each and everything that you need. So you don't need anything else to read apart from what I am asking you to do. So if I ask you to read something, then you can read it. Otherwise, lecture note is enough for pediatrics. And Dr. Kanchana, it is already there. I don't know like why we will have to send the link again. Can't you guys find out the QBank in the Facebook? There is no point of giving it again and again where it is already there. So this is your MCQ batch 10. Go to the featured section. It's not very hard. You have to do some work by yourself also, guys. I can't do all of this for you. You have to go down Right now, you should be well oriented with all of this. Where is the featured section and everything? So this is where we have uploaded the QBank. So you'll just need to open the PDF. That's it. So scroll down, read these things, because if you are a part of the course, you are supposed to know all of these things. You'll need to go through all these things that we are uploading. And I always keep the important things in the featured section. So always go there, find out if I have uploaded anything new. Okay. And also if you want to find anything important, that's always in here. And yes, you can download any books that is uploaded in the Facebook. So that's fine. You can do that. And yes, we can do reticulocyte count in any hemolytic. So any hemolytic disease, red count will be high. The carrier guideline session, yes, so I think that hasn't been uploaded, right? So I'll have a look to upload that one to the portal. So it is uploaded, right? I thought so. Let me check it again. That I thought it's been already uploaded. Yeah, it's been already uploaded. And that's right, Dr. Omar. There is a lot of previous videos which is already given. So you can like watch those videos if you're waiting for any new videos. So there is a lot of videos to go through. Okay. All right, everyone. Let's finish it here tonight. Thank you.